So Ibrexafungerp is a novel antifungal drug, a first-in-class triterpenoid inhibitor. So the problem with our relapsed refractory AML patients and MDS excess blast patients that they're in a high risk to develop invasive fungal infections, especially if they're on therapy and are post-allogeneic stem cell transplantation. Another drawback that the standard antifungals we use have toxicities and drug-drug interactions, which actually can result in the necessity to reduce the dose of targeted drugs such as venetoclax or FLT3 inhibitors. So our real-life experience with Ibrexafungerp was with 4 patients who all had relapsed refractory AML or MDS excess blast 2, were post-allo transplants with an active relapse and required therapy, and at the same time they had invasive fungal infections, candida infections or aspergillus infections, and in fact all 4 of them had their fungal infections not really controlled with standard therapy such as azoles or amphotericin B or echinocandins. So we used Ibrexafungerp either in monotherapy or in combination with amphotericin B for these patients trying to control their fungal infections. At the same time, they were receiving targeted salvage therapies with venetoclax or gilteritinib. So all 4 patients actually had clinical, radiological, and biochemical improvement with Ibrexafungerp therapy. And at the same time, they could proceed with their anti-leukemic therapy without the dose reductions of venetoclax or the risk of QT prolongations with gilteritinib. So we were very happy with this experience. The only toxicity which was related to Ibrexafungerp was episodes of nausea, which were actually controlled easily.